This is the presentation for Chapter 23, Care of Patients with Brain Injuries. Okay, so seizures, I did post a video on Blackboard regarding seizures as well, so I encourage you to go ahead and look at that video as well if you have not already done so. But just briefly, basically seizures occur when you have abnormal electrical discharges that are firing off in the brain. And depending on the type of seizure, the patient may have some type of alteration in their behavior, their sensation, or movement, or consciousness, or something like that, as you'll see as we go through the various types of seizures. So about half of seizures, the cause is they call it idiopathic, which simply means the cause is unknown in about half the seizures that you'll see in some patients. But like the other half, a lot of different things can cause seizures. You might have some type of genetic disorder of some sort. You might have a birth trauma, some type of birth trauma that causes a lack of oxygen or supply of oxygen to the brain at birth. It causes you to have seizures. Various infectious diseases like meningitis or encephalopathy, or even like brain abscesses, can cause seizures. Ingestion of different toxins like mercury or lead or carbon monoxide can cause seizures. Any type brain tumors, head trauma, or head injuries, even strokes can cause seizures. We'll see alcohol withdrawal can be a potential cause of seizures, as well as end-stage renal disease. So as you'll see, as we go through, there's different types of seizure. We have simple partial seizures, complex partial seizures, absent seizures, myoclonic seizures, general tonic-clonic seizures, atonic seizures. As well as we go throughout, you'll see the different type of seizures. So when we talk about our simple partial seizures, consciousness might not be impaired with that, whereas with our complex partial seizures, you'll probably have some type of impairment in the person's consciousness. With the partial seizures, as we'll note, which is a difference from our other seizures, partial seizures occur on one side of the brain. So you'll notice that once when you see the word unilateral, that just means one side is involved. So one side of the brain is involved. So you'll notice whatever's going on with that person, one side of that side of the body is affected. So one side of the body will be affected in a partial seizure. Okay, so when we're talking about simple partial seizures, you'll have some sensory symptoms, some autonomic symptoms, and some psychic symptoms with a partial seizure. So, or a simple partial seizure. With that simple partial seizure, you'll see maybe some flashing lights. They might, their smell might be affected, or they might start hearing things. So some auditory hallucinations. With autonomic symptoms, that's more like sweating, pupils start to dilate, they might get flushed or whatever. And then when we're talking about psychic symptoms, that's dealing with their psyche. So they might have anger all of a sudden, or all of a sudden fear, or something like that with a simple partial seizure. And then with symptoms in a complex partial seizure, you might see an altered level of consciousness, or even some amnesia with a complex partial seizure. So when we're talking about generalized seizures, this is different from partial seizures in that with generalized seizures, the whole brain is affected. So you're going to see some symptoms on both sides of the body, whereas remember with our partial seizures, we only saw signs on one side of the body because one side of the brain was affected. So that's the difference with the generalized seizures. The whole brain will be affected, so you'll have both sides of the body affected, and likely no warning will occur with these generalized seizures. So included in the generalized seizures, you have absent seizures, you have myoclonic seizures, clonic seizures, tonic-clonic seizures, and atonic seizures is what we'll go over here. Okay, so with the absent seizures, these seizures usually occur in children that are between the ages of 5 and 12, so our younger population. This is the seizure you've seen with a blank stare. They might just have a blank stare. They might have a brief loss in consciousness, and it only lasts about a few seconds, not too long, with this type of seizure. Okay, so we have our tonic versus clonic. Tonic-clonic seizures, also known as grand mal seizures, are probably your most common. The tonic phase of the seizure, that's when you'll see the muscle contractions, or muscles become, rigid. The clonic part is the jerking. I'm sure you've seen all the patients that are jerking. So put together, it's called a tonic-clonic seizure, or also known as a grand mal seizure. And so you might see them might start out with like a loud cry or something like that. They might have a change in their level of consciousness or whatnot. Body starts stiffening. In the jerking movements, you'll see they might have tongue biting, might even have some incontinence, apnea, which is stop breathing. So if they stop breathing, you might see some cyanosis or whatnot, confusion, unable to talk, drowsiness, and fatigue, as we'll talk about here shortly with the tonic-clonic seizures. With these seizures, afterwards, they're going to be, you can imagine if they're doing all this jerking and muscles tightening and relaxing and becoming very rigid, they're going to probably be really tired and sore after the seizure occurs. So they're going to be real tired, drowsy, sleepy, sore, and everything after the seizure, which is called the post-ictus stage. During the seizure, it's the ictus stage, but after the seizure will be the post-ictus stage. And so we'll note during the post-ictus stage, they're going to want to sleep, and so you're going to want to allow them to rest and just get that rest out, because they're going to be pretty tired. During the ictus stage, you don't want to restrain these patients. You don't want to put anything in their mouth. If you can get them on their side, have them on their side. So, if there is anything coming out the mouth, they don't, swallow back on it and choke or something on it. You want to protect their head. If there's any furniture, anything around, move that out of the way to protect their head. But you don't want to restrain these individuals. Okay, we have a couple other generalized seizures as well, the myoclonic and atonic type seizures. With our myoclonic seizures, they're going to have just some brief muscle jerking with their body or extremities, whereas the atonic, it's generalized muscle loss of postural muscle tone. So if you think about that, they're just really going to go limp. If they lose all their postural tone, they're going to, they're just going to go limp. If they're standing or sitting, they're just going to fall over, likely because they're going to lose all tone in their body and just go limp and fall over. So in this particular case, you have to be aware of them injuring themselves, hurting their head, because if I'm standing and I just go limp and fall over, I'm likely to hit my head. And so, there's a likelihood of injury to occur in that sense with these type seizures. Okay, so status epilepticus. Generally, your seizures will last probably anywhere from like 1 to 3 minutes or so. So you really need to time your seizures when they're occurring. If a seizure lasts for 5 or more minutes, then there's a problem, there's an issue going on, and we need to intervene with some kind of medication or something, because status epilepticus is when the seizure does not stop, it continues on, or you're just simply having back-to-back seizures without recovery. So if you're having a continuous seizure that doesn't stop for over 5 minutes, or if you're having back-to-back seizures, that means you are potentially, or you are not getting blood and oxygen to that part of the brain. So you're going to have brain damage. You can have some type of brain damage at that point if we don't get these seizures under control. If you're in status epilepticus, you're going to need some kind of medication to get that under control. So, as we stated in the previous stage, this is an emergency because with status epilepticus, this is an emergency because, as we stated, your brain's not getting the oxygen that it needs. And so not only are you going to have potential brain damage at that point, you're going to be in respiratory distress, which makes it even more life-threatening if we don't get this under control. And so, some things that could put you, at risk for status epilepticus, if you just stop taking your seizure meds all of a sudden, you're not taking your seizure medication. So you need to keep that seizure medication in your system as it's ordered on a regular basis, so you can maintain a therapeutic level in the body. And when you withdraw that medication, all of a sudden you take away that therapeutic level, and it can put you in status epilepticus. Other things, if you have a head trauma or something like that, septicemia, so some type of, blood infection or something, encephalitis or meningitis, are things that also can cause status epilepticus. Okay, so during this seizure, which is also called the ictus stage, you want to make sure you time your seizure. So as we stated on previously, a couple slides back, we want to make sure we time the seizures, because normally our seizure would last anywhere from 1 to 3 minutes. If we're having a seizure that's 5 minutes or longer, then we're entering status epilepticus, and we need to get some medication on board to help intervene with that seizure. What the patient was doing before the seizure. You want to know what this patient was doing before, because this can establish an aura. So for example, like we have here, our example was the patient picking at clothing. This can be an indicator, an aura occurs before the seizure. So if every time this person does this particular thing, whether it be picking at their clothing or whatever the thing may be, then we know they're getting ready to have a seizure. So at that point, if we know they're getting ready to have a seizure, then we want to do things to start protecting them, whether that be help them to, wherever you are, start protecting their head, help them to the floor, help them, to a soft area, get their head on a pillow or whatever, it is, wherever you are, so that you can protect that person from injury. So if you notice that they have that aura or something, you want to help them, you prepare so that they don't injure themselves. You want to know, where in the body the seizures began. So remember, like we said, if it's the one side, it would be a partial seizure, or both sides, generalized seizure. So we know what type of seizure that they're having. What are their eyes doing? All these type things can tell us, what type of seizure it may be. Again, these are just some observations to make during the ictus stage or during the actual seizure, because it'll help determine what type of seizure this patient may be having. These are just more observations that you could potentially make during the actual seizure, to determine what type of seizure, like we said, is it one side, both sides? Are they incontinent of urine or stool? Are they vomiting? Are they apneic or cyanotic? Obviously, if they're cyanotic, that's the issue. If we're in the hospital, once the seizure's over, we can have some oxygen, ready for that patient as well. Are there changes in the patient's skin color? Are they perspiring profusely? We want to make note of all these things, and we want to document these things as well once the seizure is over and the patient is safe. Okay, post-ictal assessment. Post-ictal or post-ictus is after the seizure. So ictus is during the seizure. Post-ictus is after the seizure. So when we're talking about the post-ictal assessment, we're talking about our assessment after the seizure. So of course, patent airway, right? That's our main concern. We want to make sure they have a patent airway. Do we need to give oxygen? Does that person need oxygen at this point as well? Remember, we said after our tonic-clonic seizures, they're going to be very sore. They're going to be very tired and drowsy and want to sleep. And as the nurse, you allow them to sleep. You may need to turn them on their side, just to, be on the safe, but let them sleep afterwards. But we want to make note the length of time before they regained awareness. Are they lethargic or are they confused? Do they have a headache? Do they have any speech impairments? Are they sore or anything? And then, like I said, making note of that aura before the seizure began, because that'll help you to know each time this person does this particular thing, it's likely that a seizure is getting ready to occur, and we need to help get that person prepared for that seizure. And then making note of that patient's vital signs in the post-ictal assessment as well. Okay, so during the ictus stage or during the seizure stage, we've already made note of some of these things, but just to reiterate, we're not going to restrain our patient. We're not going to move them. We're not going to put things in their mouth, turn them on their side as well, because we don't want any aspiration or anything to occur. If they fall, we're not going to move them. We're going to protect their head. We're going to move furniture and things out of the way. If it's a pillow there, get their head on the pillow or whatever, but not restraining or not moving them or anything like that. If we're in the hospital, if we have it available, have oxygen ready after, because we want to, again, make sure airway, once we're in the post-ictus stage. Call for help, whether it be, we're not in the hospital, or if we are in the hospital, have help on hand ready as well, and providing privacy for that patient. So we've covered the post-ictus stage already, but just to reiterate, having oxygen available, turn the patient on their side, afterwards, preventing any so they don't aspirate on anything. Having suction, suctioning if you need it, if you're at a place where you can, have suction if you're in a hospital or something and you have suction available. If they need to have suction available, checking their oxygen saturation, because as we stated, depending on the type of seizure, there might be some respiratory distress. So we want to make sure their oxygen level is appropriate. So checking their oxygen saturation, checking their glucose level. I didn't mention this in the previous slide, but the glucose level, low glucose levels can cause seizures as well. So checking the glucose level in the post-ictal stage to see if this was a cause for this patient's seizure that occurred. Check for any injuries. If it was a tonic-clonic, remember we said they could bite their tongue, or did they hurt themselves? Did they hit their head? Do they have any other injuries as a result of the seizure? Stay with the patient until they're fully conscious again and reoriented. Help get them reoriented and allowing them to sleep. Let them rest, let them sleep, and document your results as well. All those things that we talked about to document as well. Okay, so a transient ischemic attack, also called a TIA. So what happens, you have like a emboli is released from a thrombus. So a thrombus is a blood clot that occurs in the extremities, like your legs or something like that. And then the emboli, if it breaks loose, if that blood clot breaks loose and travel to other areas such as the brain, the heart, or lungs, and gets lodged in a blood vessel there and causing issues. So when we're talking about a TIA, we have a microemboli, the emboli that was released from a thrombus. And so it may temporarily interrupt the blood flow to a blood vessel in the brain, and causing the symptoms, signs and symptoms. So typically this is a warning that a more severe thrombotic stroke will occur. So TIAs are typically warnings that a stroke is going to occur. Probably about 50 to 80% of patients who had a stroke, they probably had a TIA. And so treatment is definitely warranted. If you do have a TIA, you definitely, this patient definitely wants to start treatment to prevent a full stroke from occurring. And so treatment might be aspirin or anticoagulants might be the treatment to minimize the risk of that patient having a stroke. Oh, the other thing I wanted to point out with this as well is it might last a few seconds to hours, and then it can resolve. It'll resolve itself, and the patient won't necessarily have any residual effects from it as well. Okay, so for a stroke, it might be called, you might see it called a stroke. You might see it called a cerebrovascular accident. You might see it called a cerebral infarction. It's all the same thing, just called different things. What happens with a stroke, which we'll talk about the various types of stroke here shortly, but there's a disruption in the blood supply to a particular area of the brain. And so as we know, the blood carries oxygen, and so if the blood supply is stopped to that area of the brain, then that area of the brain is not going to receive oxygen. So, and like I said, we'll talk about the various types of strokes here in a minute. Okay, the first type of stroke we're going to talk about is an ischemic stroke. An ischemic stroke is caused by some type of occlusion in the blood vessel. So maybe atherosclerosis, which is plaque buildup. So when we're talking about, you know, all the fatty foods and high cholesterol and things like that, that's causing like a buildup of plaque in the blood vessel. So if that plaque builds up over time and eventually starts to occlude that blood vessel, then it can cause various issues such as a stroke. Or blood clots can cause an occlusion. Remember we talked about the thrombus is you have a blood clot forming in one of the extremities or something like that. If it breaks off and travels to another area such as the brain, the heart, lungs, or something like that, then it will be called an embolus. So if an embolus travels to the brain and occludes a blood vessel there, then we would end up having a stroke. Another type of occlusion that can cause a stroke would be a tumor. A tumor in a blood vessel, in that occludes a blood vessel in the brain, can cause a stroke. Or even use of like cocaine or methamphetamines also can cause vasoconstriction in the brain and cause a stroke, preventing blood flow to get to a certain area of the brain. So our other type of stroke is hemorrhagic stroke. Hemorrhage, bleeding would cause the stroke. So remember we talked about different bleeds we can have in the brain. So any type intracerebral hemorrhage, bleeding in the brain, subarachnoid hemorrhages. So patients with high blood pressure would fall into this category if they had a stroke as a result of high blood pressure. That will fall into the category of hemorrhagic stroke. And so remember we talked about if you have all this bleeding in the brain, and then eventually it's going to build up that pressure, and so it's going to no blood flow. If the pressure continues to build up from all this blood in the brain, then it's going to prevent blood flow from getting to another part of the brain, which will cause a lack of oxygen to get to that brain, resulting in a stroke. And also, again, the use of cocaine can cause bleeding in the brain as well, causing a hemorrhagic stroke as well. Okay, so you want to make sure we're teaching our patients potential warning signs of strokes, because they want to get immediate medical attention as quickly as possible to try to alleviate effects of that stroke. So sudden weakness or numbness or tingling, loss of feeling or anything in your face, arms, and legs, if you're having trouble seeing, or some confusion or slurred speech, or any of those type things could be potential warning signs that a stroke is occurring, and you want to teach your patients to make sure they seek immediate medical attention. Other warning signs might be they just all of a sudden have this severe headache for no apparent reason, or they have difficulty walking, they can't walk, they starting to get dizzy, they not coordinated, they're blacking out, things like that. Those all might also be some warning signs that a stroke is impending. Other signs, you've heard of the acronym FAST, F-A-S-T. So stands for face, arms, speech, and time. So if their face is drooping, they can't smile, you might want to have the person ask them to smile. Their arm, they can't hold their arm up, ask them to shrug their shoulders or whatnot. speech. They can't speech. They're having difficulty speaking. Have them repeat a sentence or things like that. And then, of course, time. Call 911. We want to get them to the get some emergency medical services right away. Okay, so depending on the type of stroke your patient has, your patient will display different signs and symptoms. So we want to always do a full extensive neurologic assessment on our stroke patients. So again, that video that was posted to Blackboard last week that showed you how to complete a neurologic assessment, make sure you review that video as well. But some motor deficits that our patients may experience, they may experience weakness, or they may experience paralysis, depending on where the stroke occurred. There may be some impaired speech. They may have some difficulty swallowing, which is also called dysphagia. So we want to assess our patient for those things. So when we're talking about weakness versus paralysis or whatnot, so a person, they could have paralysis on one side or both sides or whatnot. Paralysis is complete loss of motor function. So they're not able to move it at all. Whereas hemiplegia, just one side of the body might be affected versus, both sides. Paresis is a muscle weakness. So it's not full paralysis, but, some extensive muscle weakness into, parts of the body. And hemiparesis, just one side of the body is affected. So just think hemi, Hemi, just, means the one side in both instances. Again, depending on where the stroke occurs in the brain, different things can occur. So visual disturbances, you might see difficulty in various sensations such as touch, pain, pressure. They might be disoriented. They might have some memory loss. And so there might be some language deficits as well. So then we're talking about expressive versus receptive aphasia. So if it's expressive aphasia, which is a motor deficit, so expressive aphasia, I can't express myself. So I have difficulty getting it out. I have difficulty speaking it. I have difficulty writing it. But I can understand what you're saying to me. I can understand it, but I have difficulty getting it out is expressive. Whereas receptive aphasia, I have difficulty receiving it. I have difficulty understanding written and spoken language, if that makes sense. So expressive aphasia, I can't get it out. I can't say what I want to say, but I understand what you're saying to me. Receptive aphasia, I can't understand what you're saying to me. So remember back in last week's chapters when we talked about damage to the right side or the left side. Remember, if the stroke occurs on the right side of the brain, then the left side of the body is what's going to be affected, because the right side of the brain controls the left side of the body, and vice versa. If the stroke occurs on the left side of the brain, then the right side of the body is going to be affected, because the left side of the brain controls the right side of the body. So it's opposite. The left side, if the stroke is on the left side, the right side of the body is affected. If the stroke occurs on the right side, the left side of the body is affected. So make sure you remember that, because you need to know how you're going to properly care for your patient. Also, when we're talking about left-sided versus right-sided, you need to make sure you understand which areas, which side affects different parts of the body. So if we're talking about left side, if the stroke occurred on the left side of the brain, they might have speech problems that we had talked about, so some type of aphasia. They might have difficulty with their verbal commands, so their language center, difficulty they might have. Right-sided brain damage, you might notice a short attention span. They might be easily distracted. They might have quick impulsive behavior. Okay, so when we're talking about treatment of the stroke, so remember we talked about time, getting them emergency medical treatment right away. If we have an ischemic stroke, then if we get them within about 3 to 4 hours, preferably 3 hours, within 3 hours, they can be treated with TPA, which is a clot buster. And so to break up that clot immediately, they can, have that treatment done to limit the effects of that stroke occurring. So now, if it's a hemorrhagic stroke, they're not going to give the TPA because of bleeding. It's going to cause you're already bleeding with a hemorrhagic stroke, and if you give the TPA, you're going to cause more bleeding. So you're not going to give the TPA with a hemorrhagic stroke. But if we have an ischemic stroke, then we can determine we can treat with that TPA. And so other treatments for stroke, of course, airway, right? We're always maintaining that airway, right? We want to remove any constricting clothing, put them on their side, so they don't aspirate or anything like that. Remember when we talked about increased intracranial pressure, we said we're going to elevate their head 20 to 30 degrees to prevent the intracranial pressure from rising. So like if we have that hemorrhagic stroke, their intracranial pressure is going to increase, right? Oxygen, you want to give them oxygen if they have it, if you have it available. If they need it, artificial airway, if they need it. Antihypertensive medications if it's needed, if the stroke is going to, is the result of like extreme hypertension or something like that. And IV fluids if the patient has hypoglycemia. So in the initial phase 1 of our stroke, airway, always thinking airway, right? Because if this is the initial phase, we want to make sure we maintain their airway. So we're going to monitor their breathing, monitor their respiratory rate, monitor their level of consciousness, right? Because we said if their level of consciousness is decreasing, then their condition is likely worsening. Because especially if it's a hemorrhagic stroke, their intracranial pressure may be increasing if their level of consciousness is decreasing, remember. You want to do those neurologic assessments on that patient as well. Vital signs, you need to make sure you have a baseline set of vital signs for that patient as well. You want to preserve joint and muscle functioning. So, are they, getting in some kind of therapy or something like that, and prevent any complications from occurring. So in phase 2, we're starting to get into the rehabilitation phase at this point. But again, we're still going to make sure we're maintaining a patent airway. That's always our priority. If our patient's not breathing, nothing else matters, right? Proper positioning of this patient, especially if they have some paresis or paralysis. Range of motion, keep them from getting any type of contractures by doing those range of motions. If they're not able to move, of course, they're going to be at risk for pressure ulcers. So we're going to be turning and repositioning them to prevent pressure ulcers. Make sure we're keeping them clean and dry. Or if they have urinary or stool or incontinence, keeping them clean and dry, preventing any type of skin breakdown, making sure they have adequate nutrition and fluid intake as well, and maintaining normal body functions at this point. Ongoing therapy, so our PT, OT, speech, even a psychologist dealing with a stroke and losing all your abilities can be psychologically stressful on a person. A social worker might be needed to help with any services once they leave, the facility. And also, because say if a person had a right-sided stroke, they might neglect that left side of the body because they forget about it. They don't think about it because they don't feel it, right? So you want to make sure you teach them that they need to care for both sides of their body and not neglect that side of the body, because there might be some potential to do that. Now, when we're in phase 3, we're continuing, continuing the rehabilitation process, getting them back to their optimal level of functioning. So what are our plans for discharge? Are they going home? If they're going home, do they need home health care? Do they have family at home that can care for them? Are they going to need further therapy at home? Are they going to a skilled facility? Will they need therapies in the skilled facility? What are our continuous plans for care and ensuring this patient continues to continue their rehab services and reach their optimal level of functioning? A subarachnoid hemorrhage is a bleeding in the subarachnoid space, which is the space between the arachnoid and the pia mater, the meninges. And so this is you would typically have cerebrospinal fluid in that area, but this subarachnoid hemorrhage, the likely cause is an aneurysm. And so an aneurysm is a weakened area of an arterial wall. And so the person can have this weakened arterial wall, for quite some time and may not know it. But what happens when you have blood flow that exerts pressure against the weakened arterial wall, it causes it to stretch and thin out, kind of like a balloon or whatnot. And then at that point, you get a high risk of that area rupturing. If it ruptures, the person will say something like, this is the worst headache of my life. And it literally is the worst headache ever, because you have all this bleeding in the area. And they might have nausea, vomiting, some neck stiffness, and photophobia, which is sensitivity to light. So this is life-threatening. Persons can die within a matter of minutes of this happening if it's not resolved. And so, of course, we want to make sure, we maintain a patent airway, as always. If we can get their blood pressure down, get that intracranial pressure down. They might do osmotic diuretics like a mannitol or something like that. Ventriculostomy to get that drainage, get that blood out of there. So do a cerebral ventricle drainage to drain the blood out of there, because like I said, this is life-threatening, and the person can die almost immediately after occurring. So a brain tumor occurs when normal brain tissue changes and begins to grow rapidly and abnormally. The cause is not known. Some possible causes in adults could be like chemical carcinogens or viruses or immunosuppressant agents or things like that. Depending on the location and whether it's malignant or not and how fast it's growing or not can determine what symptoms a person might experience. A person might experience different type symptoms. If they're having increased intracranial pressure, they might have headaches or something, like that. Depending on, where it is, they might have some changes in their pupils, vision or pupil changes, especially maybe if it's on the optic nerve or something like that. They might have some personality changes, changes in their mental state. They might have blurred vision or blindness. They might have difficulty speaking or vomiting. Again, all this just depends on where the tumor is and if it's cancerous, malignant meaning cancerous, or how fast it might be growing. And treatment for each person is going to be based on their each person's individual status as well. So for pretty much all of our patients, with our brain tumors, neurologic assessments, again, you got to know how to do those neurologic assessments. So if you haven't already done so, make sure you watch that video on how to do a neurologic assessment. You want to make sure you're evaluating your patient's ability to perform any ADLs. Do they need help with that, performing ADLs? Pain assessment. Do they require pain medications? Not everybody with brain tumors, depending on where it is, how large it is, might not have pain, but then they may have pain. So you want to make sure you're assessing that. And then their fears. Are they able to communicate their fears? Are they able to cope with this? How are they dealing with this? Do we need to get a social worker involved, or do we need to get anybody else involved to help this patient deal, with these issues that they might be experiencing? Okay, in meningitis, infection causes inflammation of the brain and the spinal meninges. And so you recall the meninges, the protective area over the brain and spinal cord. So that was the three meningeal membranes, the dura mater, the arachnoid, and the pia mater. And so you have an acute cerebrospinal fluid infection that causes inflammation of these meningeal membranes. And so you can have bacterial meningitis, or you can have viral meningitis. There's several different signs and symptoms you might notice with meningitis. They might have a sudden onset of fever, a severe headache, pain and stiffness in their neck when they flex it, irritability, photophobia, which is sensitivity to light. They might have hypersensitivity of their skin as well. Okay, so two key indicators that it could be meningitis. Brzezinski's sign and Koenig's sign. With Brzezinski's sign, you place the patient in a dorsal recumbent position, and then put your hands behind their neck and bend their neck forward. Pain and resistance might indicate neck injury or arthritis, but if the patient also flexes the hips and knees, chances are he or she might have meningeal irritation and inflammation, which is a sign of meningitis. Now with Koenig's sign, you place the person in a supine position. Then you flex the leg at the hip and knee. Then straighten the knee. Pain or resistance might suggest um, meningitis for this patient as well. So typically for a patient with meningitis, they probably test in the cerebral spinal, if you have test the cerebral spinal fluid, and then if you have that positive Brzezinski's and Kernig sign, then it's probably going to be diagnosed as meningitis. So with the cerebral spinal fluid pressure, is it elevated? They're going to check to see if that's elevated. They're going to see if there's protein in the cerebral spinal fluid and possibly low glucose levels. Because remember we said your cerebral spinal fluid would have glucose in it. So, and then they'll do a culture and sensitivity of the cerebral spinal fluid as well to indicate any infection as well, if it's a virus or something like that. So remember we said high temperature, so we want to control their temperature, relieve any symptoms that they might have. Antibiotics or antivirals, whatever the cause is. If it's bacterial meningitis, of course, antibiotics. If it's viral meningitis, then of course antivirals. And watch for any seizure activity that the patient might be having, and increased intracranial pressure, and all those things that we had talked about for treating and preventing intracranial pressure. We're going to do those as well for this patient. So encephalitis is just like, it's an acute inflammation of the brain, and you can get this from like ticks or mosquitoes. If you get, bites from ticks or mosquitoes, or even like complications from like chicken pox or measles or mumps or something like that. Some classic signs of encephalitis, you might see stiff neck, photophobia, which is again the sensitivity to the light, or lethargy are some classic signs you might see from that. They might have decreased level of consciousness, personality changes, seizures, confusion, flaccid paralysis. Flaccid meaning, just kind of limp. You might also see fever, or depending on, certain types of encephalitis, fever, drowsiness, nausea, vomiting, or things like that as well. So treatment of encephalitis, if it's caused by a bacterial infection of some sort, then you can give antibiotics. But if it's something more like herpes or something, you're going to, person will probably receive antivirals or something. So you're going to treat the symptoms, of course, and manage their cardiac and respiratory functions, make sure they're maintaining their strength, and trying to prevent any complications as a result of the encephalitis. These are just some other brain disorders that your book discusses: brain abscesses and headaches, trigeminal neuralgia. Trigeminal neuralgia, that's the when the trigeminal nerve is affected, so cranial nerve 5, which causes some type of facial pain. The cause of that is not really known. And then Bell's palsy, we discussed this previously. This is when the facial nerve is affected, so cranial nerve 5, and then you have some type of weakness or paralysis in the face, and it might look like the person is actually having a stroke with this Bell's palsy. So that's cranial nerve 7 is affected with that one. These are just some other brain disorders that your book discusses. Brain abscess, which is basically just a purulent or pussy material in the cavity within the brain. Headaches, trigeminal neuralgia. Trigeminal neuralgia is when the trigeminal nerve is affected, which is cranial nerve 5. So you have like a rare nerve pain or rare facial pain, and the cause of that is not really known. It probably might be due to some pressure on the nerve itself. Bell's palsy is when the facial nerve is actually affected. So cranial nerve 7 is actually affected with Bell's palsy. So you'll notice some facial weakness or paralysis. When you see this person, it might look like they're actually having a stroke because the face might be drooping or whatnot with Bell's palsy. So cranial nerve 7 is impacted with Bell's palsy.